Well, hello, good evening. My name is Bethany Iser. I'm president of the Cures Foundation. CURE stands for Comprehensive Understanding via Research and Education into Schizophrenia. And we're delighted to welcome you today to our virtual lecture with Dr. Rob Smith, Smita Sahay, and Denise Potter. And I would like to introduce Dr. Rob Smith at this time. Dr. Smith completed his BS degree with highest distinction and honors in biochemistry from Indiana University in 1990. He completed his MD and PhD degrees from the University of Michigan in 1997, and he completed a research track residency in psychiatry in 2002. He is a recipient of numerous awards, including the prestigious ACNP Travel Award, the ACP Laughlin Fellowship, the ACNP Rafelson Scholar, as well as the Camp Fund Award from the APA. He has been continuously funded for the past 19 years by NIMH, with work focusing on pathophysiology of complex brain disorders, including schizophrenia and Alzheimer's dementia. So at this time, I'd like to welcome Dr. Robert Smith.
Hey, everybody. It's exciting to be here today. Bethany and I had a lot of fun planning sort of the topic that we wanted to talk about. And after a lot of back and forth, we sort of settled on talking about metabolic stuff in schizophrenia. And we'll talk more about what that means. Just a little bit of housekeeping. I have a couple of disclosures. Neither of these activities are related in any way to anything I'm talking about today. The other sort of disclosure statement is we're going to talk a lot about research today. We're going to talk a lot about some treatments that aren't yet FDA approved. And the idea here is we're not looking to tell anybody that what their treatments are now is inappropriate or whatever. We're just here to talk about some ideas for some directions the field is going. In terms of thinking about schizophrenia as a metabolic disorder. So we're going to talk about bioenergetic deficits in schizophrenia. And bioenergetic is one of these words that kind of encompasses energy, food, glucose, ATP, insulin, the way the body gets its energy, basically. It's sort of an umbrella term. And we're going to have a three-part story today. I'm going to talk very briefly about bioenergetic deficits in schizophrenia. And then Smita Sahay is going to talk about how the ketogenic diet can change brain plasticity. Smita is an MD PhD candidate here at the University of Toledo, who's got an interest in the brain and brain science, and she's in the middle of doing her PhD. The third part will be Denise Potter, who is a registered dietitian. She is the owner and operator of Advanced Ketogenic Therapies, AKT. I've had the pleasure of getting to know Denise over the past couple of years. She's sort of part of the metabolic psychiatry cartel and has been an amazing, amazing resource for me to learn about metabolic stuff in the brain, as well as her field, which is dietary interventions for severe mental illness. Oh, I see a typo in there. Sorry about that, Bethany. So observation number one, glucose changes in schizophrenia. There's a cartoon, sort of a picture of red blood cells up at the top here. This is data from the blood. So you can measure the level of glucose in patients. And that's been done a lot in patients with schizophrenia and patients without schizophrenia. And there's fancy tests to test if that's normal. And not surprisingly, to a lot of people, if you look at hundreds and hundreds of patients, these are both meta-analyses, which bring together a lot of smaller studies. There are significant impairments in sort of glucose metabolism in schizophrenia. And this is an observation made before any patient takes any medicines. So really, when somebody is first diagnosed with schizophrenia, they can have abnormalities in their blood in glucose, and glucose is one of the major energy sources of the brain. Another observation that we've seen in schizophrenia, and this is a really nice study by Tsuyoshi Melkawa, he's a colleague of mine, and they looked at a number of brain samples from human brains, animal models, things like that, and they looked at the pH the amount of hydrogen ions, and a pH is sort of a measure of the sort of capacity of a tissue to function in a certain way. There's a normal pH range in the body. These are actually brain pH measurements. And what we know is if you're utilizing energy differently or perhaps improperly, your brain pH can be perturbed. And this is a very powerful statement regarding what's happening in the brain, potentially in schizophrenia. Another observation is there's another metabolite related to glucose. It's called lactate. It's an energy intermediate. It's sort of a way to shuttle energy around cells and between cells. We'll talk more about that later. And now we've got sort of on this picture a living human, because one of these studies was done in living humans using magnetic resonance spectroscopy and measuring this important metabolite, and found increases in lactate in persons with schizophrenia in the cortical regions. This was done by a colleague of mine, Dr. Laura Rowland. It's a really lovely study. The study on the left is lactate levels in postmortem brain and animal models, similar to the prior slide, where we moved away from the blood and now into the brain. What about in your neurons? So the brain is made up of lots of cell types. The neurons are one of them. This is a study that I published a few years back, looking at one of the major sort of features of glucose utilization, which is a couple of enzymes, hexokinase and phosphofructokinase, and the activity of these enzymes that are used to metabolize glucose is significantly decreased. It's impaired, it's broken in neurons, in the brain, in brains from patients with schizophrenia. So we've kind of talked about there's changes in living patients in their blood, in glucose. There's changes in brain tissue, in pH, lactate levels, and glucose utilization. This is a pretty significant problem. And what I want to point out to you here is that there's many types of cells in the brain. This is just two of them, neurons and astrocytes. This is the main sort of metabolic pathways, and there's lots of fancy bells and whistles here. And lactate is a major energy source. And we think that this glucose utilization, these pathways are broken and not working right. And that's an important thing to think about. A couple of final slides before we go on to Smita and change the topic here. How do the current treatments impact glucose? This is a famous study. This is called the Katie trial. It was published about 20 years ago by a bunch of famous scientists led by Jeff Lieberman. It was a multi-site trial of several antipsychotics, which are used to treat schizophrenia and treat psychosis and other disorders. And you can see what I've circled at the bottom. One of these drugs, olanzapine, was associated with increases in glucose and lipid metabolism. And what we know about most of the, or many of the antipsychotic medications, is they impair metabolism. And we used to think that it was a lifestyle issue, that these drugs were the only thing driving changes in metabolism. But what we know now is patients with schizophrenia start off with the deck stacked against them. They already have perturbations or changes in metabolism before they ever see any of the current treatments for psychosis or for schizophrenia. So this is a real problem because it kind of doubles down on what's already going on in their brains. This is a more recent study trying to get at the mechanism of how antipsychotics disrupt glucose metabolism. This is a study led by Margaret Hahn. She's at the University of Toronto. My group also contributed to this, but we had nothing to do with the figure that I'm showing you here. And this is just a simple figure. It's kind of confusing to explain. What we see here is animals where we're looking at the response of the body to synthesize glucose. All right. And the higher the bar, the more normal it is. So the red bar, the glucose in vehicle, that's how much glucose should be suppressed when you take glucose into your body. It should be blocked from being made. When you're taking olanzapine or haloperidol, which are two of the prototypical antipsychotics, it impairs the ability of the body to suppress glucose production. So this is a clear impairment of glucose regulation. It's a serious problem. So if antipsychotics make glucose worse, is there a way forward? Something to think about. So I'm going to toss this now to Smita. Smita, go ahead and take over sharing the screen. And as I mentioned earlier, Smita is a graduate student here at the University of Toledo. She's had some nice successes recently publishing papers, and she's on her way, hopefully, to being a brain doctor. We don't know what type. Smita, go ahead and take the screen.
Okay, great. Can everybody hear me okay? Hope the sound is coming through. Okay, perfect. So, yeah, my name is Smita Sahay, and I am going to be talking to you all a little bit about ketogenic interventions and neuroplasticity. So this is just an overview of what I'm going to be talking about today. I will give a brief introduction to the ketogenic
Can't see
diet.
your screen.
Okay. Can you see it now?
No. Yes.
Okay, perfect. So I'll give a brief introduction to the ketogenic diet, and then I'll talk a little bit about the evidence for the diet used as a treatment in a specific group. And then I will introduce neuroplasticity and talk about some mechanisms of ketogenic diets involving neuroplasticity. And then I'll end with a link between neuroplasticity and other neuropsychiatric disorders. So what is the ketogenic diet? Broadly, this diet is a way of eating that mimics the effects of fasting. So by consuming a diet that is really rich in fats, adequate in protein, and pretty low in net carbohydrates, the body's metabolism kind of begins to utilize fat as its main source of fuel rather than carbs. So what is ketosis? Ketosis refers to a byproduct of the breakdown of fat into usable energy called ketone bodies or ketones. This fat can be derived directly from a diet, so via nutritional ketosis, which is something we'll discuss in just a moment, or from fat stores of the body. Ketones can be used directly by the body and the brain to power itself, and this breakdown of fat into useful energy is very similar to the process that dietary carbohydrates undergo in producing glucose to fuel the body. Ketosis is defined as having a blood ketone level that's greater than 0.5 millimolar per liter of blood. So how do you get your body into ketosis? Ketogenic diets are started typically under close medical supervision, and the diet's begun very gradually, and it's increased to the full amount of fat intake over potentially a 1 or 2 week period or even longer. And this allows people to kind of adapt their lifestyle as their body shifts into utilizing fat as fuel. So during this time, blood sugar and ketone levels are monitored. And there's 2 methods to kind of make the shift from using glucose to ketones as your main source of energy. One is nutritional ketosis. So this is adopting a high fat, moderate protein, and low net carb diet. And this results in ketosis and takes approximately 2 to 3 weeks to reach a therapeutic level. However, it is highly dependent on the individual. And the other effective way to get into ketosis quickly is by fasting, which is the complete cessation of caloric intake for a prolonged period of time. But overall, I guess the main takeaway is that diets are highly individualized to each patient. So the implementation of ketogenic diets. Typically, a calorie level is determined by a dietitian for each patient, kind of based on their age and activity level. And when we talk about reaching a desired level of ketosis, the diet's calculated in terms of a ratio, and the ratio refers to the ratio of macromolecules. So there will be typically you'll see 4 to 1, 3 to 1, 2 to 1, etc. And in a 4 to 1 ratio, this just means that there's 4 times as much fat as there is protein and carbohydrate combined. Typically, the 4 to 1 or 3 to 1 diets are not really done in adults because they're not able to get adequate amounts of protein. So then the dietitian devises meal plans that complete the required fat, protein, and carbohydrate for each meal. And the meal plan indicates the exact weight of each food that can be weighed on a food scale in grams. So a typical meal includes a small amount of fruit or vegetables, a protein-rich food, and some source of fat, such as heavy cream, cooking in butter, or oil. Again, highly dependent on the individual. So there are different types of ketogenic diets. The first one that we hear about is the classic ketogenic diet, which is comprised of about 90% of fat and very low proteins and carbohydrate percentages. There's the modified ketogenic diet, which is slightly more forgiving and less restrictive in terms of the fat content. And then there is the MCT diet, known as the medium chain triglyceride diet. MCT is a specific type of fat, and in this diet, that is the type of fat you are mostly consuming, but it allows the patient to take in slightly more protein and carbohydrates in their diet. There's also the modified Atkins diet, which limits the amount of carbs, but encourages a higher protein intake. And then there's the low glycemic index, which maintains that protein intake, but slightly increases the amount of carbs that a person can have. And then lastly, as we talked about, fasting is a way that you can get into ketosis. And usually intermittent fasting requires a person to eat during a very restrictive window, typically within an 8 to 10 hour window, and the other 16 hours they're not eating. But in practice, really a combination of all of the above are used, not just one or the other. So what is the efficacy of this diet? It has been widely popular among the drug-resistant epilepsy group. So drug-resistant epilepsy represents about a quarter of epilepsies worldwide, and it is a group of patients who have epilepsy that don't receive adequate treatment with their medication regimen alone. So although, ketogenic diets have been used for drug-resistant epilepsy since about the 1920s, the past 15 years have witnessed a huge explosion of the diet use in the management of epilepsy. So the diet is considered a very potent anti-epileptic treatment for this group. And so next, I kind of want to review some evidence from randomized controlled trials regarding the efficacy and safety of implementing this diet in this population. So this is the first study where they really wanted to examine the efficacy and tolerability of the classical and the medium chain triglyceride versions of the ketogenic diet at 3 different time points, 3, 6, and 12 months. And what they found after these diets were implemented in 2 groups, that there was really no significant difference in baseline seizures between the 2 groups at any of the time points. And there was also no significant difference in tolerability of the diet, except there were some increased reports of lack of energy and vomiting after 3 and 12 months, respectively, for the classic ketogenic diet group. And so the main takeaway from this study was that the classic and MCT ketogenic diet protocols are pretty comparable in efficacy and tolerability. Another study wanted to compare the efficacy of a gradual ketogenic diet initiation with the standard ketogenic diet initiation preceded by a 24 to 48 hour fast. So in the fasting group, they found that 58% of children had greater than 50% reduction in their seizure type at 3 months, and 21% were absolutely seizure-free. Whereas in the group where the ketogenic diet was gradually increased, 67% had greater than 50% reduction at 3 months, and 21%, so the same amount, were completely seizure-free. Also, children in the gradual arm lost significantly less weight, and they had fewer and less severe episodes of hypoglycemia. So the main takeaway kind of from this study was that in children with drug-resistant epilepsy, a gradual initiation results in fewer adverse events, and it's tolerated better overall while maintaining the efficacy of the diet. In this study, the researchers wanted to compare the anti-epileptic efficacy and diet tolerability of 2 different diets with lipid to non-lipid ratios of 3:1 and 4:1. So in this study, they found that the anti-epileptic efficacy was higher in the 4:1 diet. 55% of the patients on the 4:1 diet and 31% on the 3:1 diet became completely seizure-free. However, they found that the tolerability of the diet was better for the 3:1 diet, as they had less frequent GI symptoms, which makes sense because it was less restrictive in terms of the fat content that they were taking in. But overall, the 4:1 diet showed greater anti-epileptic efficacy than the 3:1 diet with higher seizure-free outcome. And in most cases, the seizure-free outcome was maintained even after they changed the ratio to 3:1. And then very lastly, I wanted to talk about this study where they assessed the efficacy of the modified Atkins diet and the low glycemic index therapy regarding seizure reduction at 24 weeks among children aged 1 to 15 years. So what they found was that the median reduction in seizure burden among the 158 children in this study was similar with all three of the diets. And the adverse events were the least with the low glycemic index therapy diet. So overall, this study supported that guidelines should support the use of a ketogenic diet, modified Atkins diet, and low glycemic index therapy diet for managing drug-resistant epilepsy. So we've kind of discussed the diet and a little bit of its efficacy. So the big question kind of remains of what is changing in the brain to make people stop seizing. And one way we like to think about this is in terms of neuroplasticity. So what is neuroplasticity? Neuroplasticity is the ability of a system to reversibly alter in response to a stimulus. So a phenomena here that we like to talk about is change and then change back. If you can kind of imagine a plastic water bottle, crumpling it up and then bringing it back to its form, that kind of, it's a visual to kind of show what plasticity means in this context. The brain can do the same thing, but how? The brain can change via formation of new circuits by strengthening and weakening of the synapses. There can also be an alteration in the number of neurons or other support cells in the brain, such as the glial cells, via cell division or cell death. And lastly, the brain can change in response to a change in environment in terms of learning, memory formation, and various cognitive processes. So what are the proposed mechanisms by which a diet might change neuroplasticity? I'm going to talk about 3 of the proposed mechanisms. The first being, there may be an increase in a protein called brain-derived neurotrophic factor, BDNF. So BDNF is a protein that promotes growth, survival, and differentiation of neurons, and ketosis has been associated with elevated levels of this protein. BDNF plays a very crucial role in neuroplasticity, which is the ability of synapses to strengthen or weaken over time in response to activity. And higher levels of BDNF support neuroplasticity by facilitating formation of new connections between neurons and enhancing learning and memory. Another proposed mechanism is via enhanced mitochondrial function. So ketosis promotes the production of ketone bodies, which serve as alternative energy substrates for the brain when glucose availability is limited, such as when you're fasting or on the ketogenic diet, of course. And ketones are efficiently metabolized by neurons, and they've been shown to enhance mitochondrial function. And this type of improved function supports neuroplasticity by providing neurons with energy that's needed for brain remodeling. And then the last theory is via reduction in inflammation. So ketosis is associated with reduced inflammation in our brains. When we have excessive inflammation, this impairs neuroplasticity by damaging neuronal structures and interfering with signaling pathways that are involved in neuroplasticity. So by mitigating the inflammation, ketones or ketosis may create a more favorable environment for neuroplasticity to occur. So then we kind of start to think about if the ketogenic diet changes neuroplasticity, what other disorders may benefit from this diet? Some disorders of neuroplasticity. So typically these disorders are not, they're not typically known as disorders of neuroplasticity, but they include Alzheimer's disease, Parkinson's, autism spectrum disorder, major depressive disorder, traumatic brain injuries, and even schizophrenia. So schizophrenia was not always known as a disorder of neuroplasticity, as I was saying. This is a paper that Dr. Smith published in 2004 that kind of recapitulates schizophrenia as a disorder of neuroplasticity. So therefore, theoretically, ketogenic diets should also be effective in this population. And to date, there have been a few case reports that show the efficacy of ketogenic diets in schizophrenia. And Denise specifically works with patients in this population. So I'm going to hand it off to her now, and she will present some case studies where she's seen success with the diet in patients with schizophrenia.
Thanks for that, Smita. And Denise is going to share her screen, but you have to stop sharing yours. That was the problem before. And as I mentioned earlier, Denise Potter is a registered dietitian, but she's done transformative work implementing interventions for people in a really amazing way. And I'm so excited that she got to be part of this talk today, because every time she has something to say, I usually learn several new things. So I'm really excited that you're here today, Denise. Thank you for your time, and the floor is yours.
Wow. Thanks for having me. I get really excited, and thank you guys for going through all the science, because then I get to do what I think is the fun part and talk about the people because that's where I live. And so I'm going to talk, obviously, here, schizophrenia and serious mental illness, and that is a target for ketogenic therapies. And I'm assuming you guys are seeing my screen okay? Correct? Okay. All right. Sure. Okay. Here are my disclosures. And the most important one is that I am a shameless advocate of ketogenic metabolic therapy. Our objectives today would be to review clinical evidence of KMT. I'm just going to say KMT for ketogenic metabolic therapy and serious mental illness, and then review a couple of case studies of people that I have worked with in the past, one I worked with in the past, and one I'm currently working with. And so, yeah, we'll take a look at those. A little bit more of the evidence. This study, super recent study that came out 2022, I believe. Dr. Denon is a psychiatrist in France, and he, on his own, he put 31 of his patients, while they were inpatient, onto a ketogenic therapy. And in France, it's a little different, where we may have a lot of more initiated admissions. They have a lot more freedom to say, well, I'm not feeling well, I'm just going to go in and be admitted. So not exactly like the US system, but the benefits that he saw with the 28 out of the 31 people were able to maintain the diet for a period of time. With schizoaffective disorder and bipolar disorder, he saw 62 and 74% improvement. With major depressive disorder, 75 and 78% improvements on the scales. There, I believe, out of the numbers, there were 6 or 7 people that had MDD, and only one of them still had MDD after they did their scales at the end. Their metabolic health improved, which means they're losing weight, their glucose is better, their blood pressure and those things are better. He proved, with this study, that the diet was feasible and well tolerated in this population, in this situation, which is really important, because that helps us when they start doing research. We have to prove, before you launch into studies, that it's tolerable and that it's safe. And he did that. And this was just really, to me, a landmark study. The next report study is very interesting, because Dr. Ian Campbell is a researcher in the UK, and this is an online report of online study of reports that people were having sending in, and just people on the internet saying, I'm doing ketogenic diet, or I'm doing Mediterranean diet, I'm doing, different, what things were they doing and what benefits were they receiving. The reason Dr. Campbell did this is because, and he has on some great podcasts, if you look him up, is because he has bipolar disorder, and he went on a ketogenic therapy, a low carb therapy, to lose weight, and inadvertently started feeling much, much better. And so he wanted to start researching this, and that led to more studying and more research, just kept compounding. And what he found was great response, with people reporting mood stabilization, less depression, improved clarity, increased energy. And the remission of symptoms was more prevalent with ketogenic diet, than other diets that people were reporting. So that was really exciting. That led him on to say, wow, now I can do a pilot trial. And I will just give a shout out to the Bazooki Foundation and Metabolic Mind, because they're supporting a lot of this research. And so he did a pilot trial, and this was very recently published, and they had great results here too, which is cool. And I'm just going to jump to the next slide, because it lays them out a little easier for us. 95% of the people had intentional weight loss, because of course many of these people on these medications have gained weight that they didn't want. It's purely because of the meds. 91% of the time they were in ketosis, which is great. It wasn't a huge study. It was, wow, now I'm forgetting how many people, if it was 30-ish, 27 or 30. So most of them spent most of their time in ketosis. This isn't a result, I apologize, but they individualized the diet, and it was provided by a registered dietitian who was familiar with ketogenic therapies, who had great experience. So Helen Grossi, I believe, was her name. And so she did a fabulous job with monitoring these people and helping them stay in ketosis on the diet. They had decreased lactic acid and glutamate on the diet. And without going into too much detail, we know lactic acid builds up in people and in other conditions. There's one called pyruvate dehydrogenase deficiency. We put children usually on ketogenic therapies to decrease those levels, and it helps their symptoms, very much helps them. And then decreased glutamate, the glutamate's high in schizophrenia. Decreased glutamate when someone's on a medication is considered a positive treatment response. And what's really amazing here is that they had a 10% reduction in glutamate in only 8 weeks on the diet. And for a literature review by Dr. Campbell, medications only caused a 6% reduction in glutamate. So, I can't interpret all that, but it's very exciting direction to, just as, again, in the early study, early formative times, as we're learning about this. He also showed that most people had improved mood, decreased anxiety, and decreased impulsivity. So really exciting information. The process that they used, and I like to highlight this because this is pretty much what we do in my practice. They medically screened them. That means we're doing labs. We're looking at their health history. There really, honestly, are very few reasons not to do a ketogenic therapy, and I'm not going to list those all out here. Those, and again, we're not telling anybody to do this, but I will say that those are listed out on the Charlie Foundation website, and that you should be very cautious and if anybody does pursue a ketogenic therapy, it should always be under a physician's guidance and hopefully a registered dietitian that knows, or nutritionist that is familiar with that therapy. Just to clarify that. Diet selection was then the next thing that they would do. What kind of a diet do we put them on? And Smita already kind of went through and showed, wow, here are the 5 ketogenic diets, ketogenic therapies that we can pick from. And sometimes we take the best of all of those. And that's kind of what she was alluding to. We have all these individualized, and they are studied as individual diets, and that's great. But what I find in common practice, myself and a lot of my colleagues will do, is say, wow, we love MCT oil, and we love keeping the carbs on the low glycemic end and the different things. And we just combine those to create our best plan for people. We then spend time preparing and educating them, and that takes some time. It takes some time. People do come in now with a lot more information and background on keto because there is so much more on social media now and on the internet. And then the diet initiation, as also Smita mentioned, is usually a lot of times slowly done outpatient, but in the study, I'm thinking that they probably did it much quicker. I honestly don't know that for a fact, how quickly they did it, but usually in an 8-week study, they're going to initiate a little quicker, but we tend to be kind of cautious with that when you have the time. They're going to supplement. We very frequently supplement ketogenic therapies with a few specific things that might be missing in that type of a diet, because you are limiting some really great foods and some healthy foods. And we don't love that, but this is a medical therapy, and we do have to look at it that way. The last thing is these people were managed and they were followed up on a frequent basis, usually weekly, on a study like this, by the dietitian and by the physicians. Okay, so we'll jump right into my case studies, and I get really excited. I kind of geek out on this because, these are just stock photos. They're not the actual people for their anonymity, but this gentleman had schizoaffective disorder. I started working with him about 3 years ago, 3 to 3.5 years ago, and he's 30 years old. He was very obese. He was depressed. He was having hallucinations. He was homebound. He really wasn't getting out at all. He was very dependent on his mother. He was unemployable. So financially and socially, he's having a really difficult time. His obesity was largely caused by one of his medications. He'd gained 80 pounds on one of his medications, you'll see there. His diet was pretty typical. It wasn't anything excessive. It was a typical American diet, so nothing noteworthy there. The only noteworthy thing was the almond milk, and I mentioned that because it does have added calcium, and he was drinking excessive amounts of almond milk, which worried me that he was just getting too much calcium and might develop renal stones or something. Clinically, we do, we can't do a full, I do most things online. We can't do a full physical assessment, but we, just take a look at them, and then we have their doctors, their physicians are doing the nutrition focused physical exam to make sure they're okay. And his lab work, which we review, typical lab work that you would have done at a physical, at your, physical at the doctor's office. So we're looking at a lipid profile, your metabolic panel that looks at your liver, and your renal panel, your kidney function. We take a look at your vitamin D, another one called carnitine that we keep an eye on a ketogenic therapy. And if we can get a hemoglobin A1C, fasting insulin levels, those type of things, we want to get those too. So his lab work was okay. I don't know that I had the A1C and the fasting insulin though. So our plan with him, we went ahead and did a couple hours of education. I like to see people over a 3-month period. I always tell them I don't have a keto diet just to hand you, they can find that somewhere else. We like to work with people over an extended period of time so we can be real thorough and help them out. And I don't have this anywhere else, so I'm going to mention it now. We treat the diet very much like I would for epilepsy. So with epilepsy, we tell people a minimum of 3 months, 3.2 if you look at the pediatric studies. 3.2 months is to when you can say, wow, this may or may not really work. I push adults out to at least 4 months. So I tend to say and with mental illnesses that we need to look at a 4-month trial of the diet. So again, we spend a couple hours on education. This keto diet calculator is a program my friend Beth at the Charlie Foundation designed. We use it when we want to do what we call precision keto. And I love starting people out precise if they have the bandwidth to do that. Many people with this serious mental illness, that's not something they can do. But very frequently, the family's running the show for this. This gentleman was kind of a middle ground between the family, between his mother and himself helping. He was more participatory than some people I work with. So I showed them how to use that program. Their plan was this 1.5 to 1 ratio. Now, to give perspective on that, a lot of people are thinking macros. So if you've heard of macros, we'd say that's about 75 to 77% fat. And then the protein and carb is less than 10%, probably 5% carb, and then the rest would be protein. Calories around 1,800. We're not really nitpicking that. We're trying to find an amount that just he's satisfied with. He's getting enough to eat, but he's still losing weight because he did want to lose weight. That was definitely a goal. He had weekly weekly Zoom support, weekly, sometimes bi-weekly. And he notified his physician, and that's always a request we have, that you let your physician know that you're pursuing a ketogenic therapy. We don't want people just out doing this on their own. Let's talk about his outcomes, because this is where the money is, where the magic happens, so to speak. Within his first month on this therapy, and let me just say that he was very flat every time we spoke. His mood was improved. He was losing weight nice and slowly, pound a week, nothing fancy. His mom was helping transition the recipes. She had a lot of recipes on Pinterest that she liked. And so she would pull recipes off. We'd take a look at them. We'd adapt them to make them more ketogenic. Because even though a recipe says keto online, guess what? It might not really be keto enough, so to speak, to really keep you in ketosis. So we did a little adaptation there. His ketones, or the BHB means beta hydroxybutyrate, tested with a meter, and it's a meter, it's a glucose and ketone meter. So finger poke once a day. His ketones were usually over 2. That's great. That's where I like to keep adults. I push kids a lot higher because it's easier for them, but adults, that's a great number. So we wiggle that keto ratio on up to a 2 to 1. So now he's up in the 80% fat range, a little higher than 80%. So that's a lot of fat when you look at a meal. Calorie wise, again, he's kind of reducing, just self-reducing, because he didn't need really that full 1,800. And then significantly is MCT oil here, 60 grams a day. Now that translates into 4 tablespoons a day. And please don't anybody go out and just start 4 tablespoons of MCT oil, or you will be in the bathroom. Let's just say that. That's a whole nother talk, but MCT oil is, we work that up very slowly. At 3 months, what's happening? So at 3 months, his BMI's dropped 2 points. His BHB is still rolling in that 2 to 4 range, where I'm real happy with that. He's reporting increased energy, clarity. His sleep has normalized. His hallucinations are still there, but they're less intrusive. Of course, we're happy about that. And overall, his quality of life has improved. At this point, he said, I'm going to start, I've started going out for walks. I'm going around the block. And I'm like, oh my gosh, that's amazing. You're going out for walks. This is so cool. And so, you know, we're really happy with this visit. Usually at this point, we transition to what I call monthly monitoring. 1 call a month. They can send me emails in between, all that. And so we were doing that. They signed up for that. They paid for that, but they didn't make any appointments. And I several times emailed them, hey, please make an appointment. Please make an appointment. At this point, I'm getting worried. What's going on? Are they going off the diet? You know, I don't know what's happening. And so didn't hear anything from them. Finally, they scheduled an appointment about 6 months later. So now we're 9 months in. I'm super worried because I've seen people fall off. Here's our outcomes at 9 months. He's just self-regulated down to even a lower calorie amount. That's fine, no problem there. His carbs are CHO's carbohydrate. He's at about 20 grams of carb or less. MCT oil, he's kind of just lowered that on his own. That's fine. And he's eyeballing his food now. He's not measuring. And that's always my goal. I'll tell people, even if we start out measuring food really strictly, I'll say within, you know, a few weeks, a month or 2, I want you to break up with the scale. So he's done that. That's perfect. But look what's going on here. His auditory hallucinations, they're not all the way gone. They're stable and they're very mild. His obesity, boom, getting a lot better. He averaged about 1 pound a week at that point. Depressed mood, gone. Lethargy, gone. Housebound. Here's how I know the housebound is resolved. Well, one, he was starting to go to the gym. He said when he got on the call, he said, yeah, I just got back from skiing in Colorado with my friends. I'm just going to let that sink in a minute, because every time I say it, I almost want to cry. He couldn't, oh my gosh, he couldn't leave the house when I met him. And here he is. He went on a trip. I said, you got on an airplane? That's what I said. I'm like, you got on an airplane and you went to Colorado. And what I didn't say though, I said, and you had friends to go with, because that's super significant because he was very isolated socially because of his condition. So that was amazing. Medications were unchanged. There was no change in his medications. You saw he was on several. That was not a goal for him. And I'll just make quick mention of that, because very often here with ketogenic therapies, people are very anxious to get off medications, or they want to change their meds. And, you know, when I start ketogenic therapies, you know, they're following with their doctor and they just start keto. We don't change medications. We just, let's see what's happening. And that's up to their physician to make those changes. That's really scary when people start messing with their meds. So there can be appropriate reductions, when the time comes. But again, that wasn't his goal. And I think it's kind of cool that, you know, we're just there. Anyway, so that's great. And that's the end. The end of that story is I was going to present and tell about him at a talk, and I hadn't heard anything from him in a couple of years. And I may or may not have done a little bit of, let's just say creeping, look, you know, to kind of see where is this person now. And anyway, he, per some social media, just kind of, it sounds weird, but you know, I just looked up because we can. And I found him, and he had a great big smile on his face, first of all, in the photo, which was exciting because I'd never seen him smile. He looked like he'd lost a bunch more weight. Wow, you can't fake that. So I'm just saying, you can't fake the smile, you can't fake the weight. Said he'd been working a job for 2.5 years. That may or may not be fiction. I don't know. But the weight and the smile were for real. So again, that's a happy ending to that story. And this next gentleman that I'm currently working with, and this is such an exciting story as well. His diagnosis is schizophrenia. All these other things, I'm not going to read them all. They were all listed as over the years of conditions that he was labeled with. Just a 23-year-old young man. He was violent. He was aggressive. He's literally kicked out of 3 facilities. He had started having depression at 14. He was a very high achiever, a great student, bright future, as many people with this condition are. And anyway, so went through struggles from college age, from about 19 to 23. He was in 12 treatment centers. He was hospitalized 20 to 30 times. His mom wasn't even sure exactly how many, because there were so many. Over 12 psychiatrists, 22 plus medications. She got to 22, honestly, and stopped counting, and there may have been more. The out-of-pocket cost, this is just the family's cost, this is not health insurance, was over $1 million in 4 years. The medication side effects he experienced, 30-pound weight gain, sedation, agoraphobia, which, again, the other gentleman couldn't leave the house, so it kind of goes along there, sexual dysfunction, akathisia, blurred vision, drooling. So just things are not going well at all. What we did, and this is it always comes down, at least in my situation, to great families. Mom had put him into an inpatient program, but first he had to go through the acute phase of the program. Well, he never actually got well enough in the acute phase of the program, because he got even more psychotic when he went into the treatment program. And mom thinks it was probably because of what they were feeding him, because she kind of had him on a whole foods diet at home, and he got in there and was eating a lot of sugar and a lot of sweets. So anyway, the psychosis got worse. It was maybe have been underlying before he went in, got worse. So mom actually took him out, AMA, against medical advice, home to start ketogenic therapy. You can see he was on 3 medications. And let's see what else that's here that I didn't say. We checked his pre-diet labs. His weight's 190. That's with that 30-pound weight gain. And that 30 pounds was gained in that 11 weeks. It was a really quick weight gain with medications. His symptoms, this is not, and Dr. Smith, I apologize, because this is not like what you would see of psychiatrists ranking symptoms. This is a dietitian saying, hey, let's evaluate these things before we get started. His anxiety on a scale 1 to 10 is a 5. He's very paranoid. He's in psychosis. His depression is PHQ-8. This is one scale we do to kind of evaluate, and it was 21, which is quite high. Motivation, everything's really honestly very terrible. He was very flat. I worked 99% with mom. He was not capable of working with me, with the dietitian, as a lot of my clients aren't. It's mostly we work with the families. He used to be a very charismatic person, but he's not. His focus is poor. He can't read. He can't concentrate. So what we did, already what mom had done a little bit, she was sending him some keto meals in the inpatient facility, but we don't know, fully how much of that he was getting. The clozapine was introduced during that last 11 weeks, so that was a relatively new medication for him. He had been on it previously and failed it, but he wasn't on it very long previously, so it wasn't a super good trial before. His diet was initiated on August 1st of last year, and we started that 1.51 ratio again. That's where I tend to start people, because it's high enough that they can get into ketosis, but not so high that they just can't do it and can't eat the fat. We started with MCT oil 3 times a day in small doses and work that up. We have standard supplements. Again, nothing fancy there. We initiate it gradually. Gradually to me usually means let's start with just keto breakfast or keto lunch. I don't care. Pick one. Let's eat that for 2 or 3 days, get used to it. And then let's go to the next meal, make that meal keto. And then let's go to the next meal and just gradually work it in. And then let's hit snacks. So people might get it hit into ketosis within that week or 2 window. I like to do that, especially with psychiatric people on psychiatric meds, because we don't know the impact of ketosis on their medications. We see this in epilepsy where people will have side effects they never had before because of the metabolic change. And I don't know why that all is. Maybe Dr. Smith could explain it better than me, but we see those changes happen. So we don't want someone to just shoot right into ketosis or just, oh, I'm going to fast for 3 days and go into ketosis. That terrifies me if someone tells me they're doing that. I have someone we were going to work with that that went into ketosis really quickly, lost 30 pounds, and then they landed in the hospital before we could start working with them. And so it's really, again, can't really stress enough how dangerous this can be to just embark on your own. Anyway, moving along, we'll tweak the diet, maybe, sometimes some intermittent fasting, like Smita mentioned. We're pushing that MCT oil up because that can be real critical for getting ketones. And then follow-up is basically weekly or every other week. And what that looks like for me is we're reviewing progress, we're making adjustments in the diet, we're seeing what's working, what's not working. Is this too hard? What do we need to fix? We're looking at labs, we're talking about GI. I have to talk to everybody about poop. Some people get constipated on keto, and so we're most certainly are just trying to mitigate that. We try to mitigate it with food rather than medicine if we can. And again, just talking about the tolerance. These are pictures sent to me, not by this particular patient, but by another one, and just fabulous ideas of how wonderful a ketogenic therapy can be. Sometimes people, and even dietitians, they can be critical, thinking, oh, that's not healthy. You can't eat healthy on that. And you really can eat quite a varied diet. So what are our results? Well, after 2 weeks, mom's already saying, this is the longest time of calm he's had in 3 years. When he was home, even on whole foods diet, which she told me that had really helped him. And so I was encouraged that this might help. If a whole foods diet was good, maybe keto will be better. And even on that, she said he was in the hospital 3 times. And so she's saying, and I put these quotes down because, you want to remember, you want to see, because sometimes it's very subjective, and making good progress. So we're happy about that. He was saying the lights he sees, would see lights all the time, like a disco ball, and those were starting to go down. Well, fast forward to 6 months, and this is where we're at right now. This is super current, right where we're at. His mania and anxiety resolved. Paranoia and psychosis gone. Depression, he did a PHQ-8 this week. It's a 2. It's virtually not depressed. His motivation is good. His compulsions are resolved. His affect is normal. And unfortunately, there was a loss in that family. And he was showing compassion to his mother. And if any of you, and I'm sure many of you are dealing with, any family members with this condition, you can understand that that may be unusual. His focus is very good. He's now reading. He's insightful. He's making career plans. He's playing the piano again. He's playing video games. He couldn't do that. So just many of these normal things are happening. During this time period, medications were starting to be reduced. And honestly, his psychiatrist was a little bit, what do I want to say? Skeptical is the word. He's a little bit skeptical. But after a couple of visits, he was supportive of helping mom slowly titrate down on his meds. So a couple of specific things. Oh, I missed this. Sorry. And this is what mom's saying, and therapist is he's showing no signs of schizophrenia, which is amazing. But here's what happened at 5 months. I couldn't decide which slide to put here first, but this happened. He got off his routine. His sleep, someone who was in charge of his meds for a few days didn't give them on schedule. They gave him unlimited cigarettes. He was down to 2 a day. His mom was out of town. His ketones dropped. And the great thing is that after 2 days, even though he was close to psychosis, he called his mom. He was insightful enough to still call her. His dad was able to fly in overnight, took a red eye, got to him. I'm assuming kicked the other guy out who was supposed to be helping, got everything back in line, made sure his food wasn't really out of line. His ketones went down a little, but they always go down a little when mom was gone, but he didn't lose control. But when the meds and everything else were off, that kind of threw him off. Anyway, it took 5 days to see improvement. And coincidentally, I had a patient with bipolar who did a very similar thing, she went off the diet though, and in 5 days of being back on her schedule, her routine and her diet, she also got better. So it's really interesting. I don't know if there's anything magical about that. It just happens to be 2 people I've worked with. Anyway, a few other relevant pieces of information here I just want to toss up. His clozapine is 50% weaned, and they continue to titrate down on that. So he's seen improvements with medication decreases. He is getting hyperbaric oxygen twice a week. Mom feels that's impactful for what he's doing. So this is a holistic therapy. It's not just one thing happening here with keto. He's on the supplements. I mentioned he needed carnitine because that was low, not uncommon in keto. Other basics, his MCT is up to 4 tablespoons a day. Again, pretty tight dietitian support, stellar family support. I can't say enough about this mom and how much she's doing to help her son. And then now she's already out helping others and spreading the word of this treatment. His compliance, 100%. Now, that doesn't mean that everybody has to have 100% compliance, but his compliance was very good. They really restricted what, foods were available to him. So he didn't have the temptations and problems to be exposed to a lot of other things. And right now, while his brain is healing and his neuroplasticity is improving and coming back, we're happy with that. And then I noted here also that his ketones drop when his mom travels. And I think, when someone's stress level goes up, your glucose goes up, and that causes your ketones to drop. And that's probably what's happening there when his rock, she's his rock, basically his pillar. When she's gone, it's a little harder. But, and his diet stays exactly the same. So it's really interesting. Sometimes it's not the diet. So, so 2 great stories. So the questions that I'd like to ask, is keto off label? And I think we can agree that it is off label. But then the question becomes, as we look at this, is this an appropriate therapy? Does it matter that it's off label? Because medications commonly are prescribed off label. So many of the medications utilized for schizophrenia and serious mental illnesses are off-label medications. And Dr. Palmer talks about this and, is far more qualified than me to discuss this. But off-label just means as long as the physician has evaluated the medication and seen that it is showing promise in one area or showing promise for some people, that they can appropriately prescribe that medication for another condition. And so it doesn't mean that it's improper. It doesn't mean it's illegal, contraindicated, or even investigational. So by definition, I would challenge that off-label is, ketogenic therapy, if guided by a physician, may be an appropriate therapy for some people with these conditions. So I propose that we consider that this be ketogenic metabolic therapy be strongly considered in serious mental illnesses. But again, as research becomes available, and Dr. Smith's involved in that, and many people at here, would really want to highlight Metabolic Mind. This is a great website to go and see research that's current, research that's published, and research that's projected in these conditions, because we need the research, but also we have these people that are saying, while the research is coming, I want to go ahead and, and pursue these therapies, again, under the guidance of their healthcare team. And lastly, this is a study that I'm involved with that's just about to launch. Anyway, well, thank you for that. Thank you for just allowing me to be here and then just brag about the families that have worked so hard to help their loved ones get better.
Dr. Smith, do we have just a few minutes to take some questions?
Yeah, and there's a few questions in the chat, and I just want to thank Smita and Denise for a wonderful presentation. The other thing I'll say is, in the field of medicine, the gold standard is what we call a randomized controlled trial, or an RCT. And that's typically, but not always, comparing two treatments. placebo versus a pill, a drug, a regular diet or a Mediterranean diet versus another diet, a ketogenic diet or a ketone supplement. Right now, there's a lot of RCTs, randomized clinical trials launching. So the gold standard evidence is not there yet for schizophrenia and bipolar. It's coming soon. What I will say, and if you listen closely to Smita's talk, there are more than 6 RCTs for the treatment of epilepsy with the ketogenic diet. All were efficacious with medium to large effect sizes. So we know this intervention changes the brain. We know that. When you change the brain, when you change the stuff that causes epilepsy, would that also help schizophrenia? Denise's really wonderful cases suggest yes, but we're waiting for that sort of gold standard evidence, but that doesn't mean you have to wait. There's a bunch of questions in the chat. Denise, some of them may be for you. Let me back up here and see what it says. Oh, there's a nice question. Denise, is the ketogenic diet suitable for people with chronic kidney disease?
Ooh.
Because there's a lot of protein that you take, and you want to.
Well, that's, you know, we evaluate that on a case-by-case basis. I will say that there is evidence that it's actually useful in polycystic kidney disease, and we're utilizing the diet for that. And the diet is actually, when you do the diet to a decent enough level to have good ketones, you're probably eating less protein than you would eat on a normal American diet. And I'll say that usually the levels are kind of similar to what someone would get on a renal diet. So we're not giving, you know, when someone does a modified Atkins, that's a whole nother day. And they're just, you know, and they're eating excessive protein, or a carnivore diet. That's different. That's not really what we're talking about here. So that's really, that needs to be evaluated by their doctor. And even when I have someone come in with like that, we had someone with an eating disorder come in straight with just barely out of renal failure, kind of actually still in mild renal failure. And I consulted with a specialist dietitian in renal before we moved forward, and her renal function improved while she was on the diet. She was improving when she started, but I'm just saying, but that was under guidance of renal and a renal dietitian and myself.
As my son is on clozapine, which causes constipation, he's on daily Miralax. How does a keto diet affect constipation? That would concern me.
So most definitely, if I had to say what's the one side effect that is most common on keto, I'd say constipation. And if that's the worst, you know, someone has. But so when we have people come in already with constipation, we have to address that. So that's, you know, we talk about poop every call. And so literally we're saying, what are your fluids? Are you know, we're pushing avocados and chia and flax and trying to get people, a lot of times we get them off Miralax, eating a healthier, you know, diet. Sometimes it depends how they're eating. Sometimes people eat too much fiber and don't drink enough water. So that's an individual, and that's an issue whether they do keto or not, that hopefully they can maybe talk to a dietitian and get some help to, you know, to mitigate that anyway. But yeah, it doesn't stop us from doing that. Most of the kids we work with, really high percentage of these children with epilepsy have neuro issues, low tone, and a lot of constipation. So it's our favorite thing.
The next question, and there's a few, and I want to try to get to them all. Can someone achieve ketosis on the antipsychotic olanzapine? Same question for quetiapine or Seroquel. I'll take this one. Yes, you can do a ketogenic diet while you're taking an antipsychotic. I think Denise is always going to recommend that you work closely with your physician, your psychiatrist. Nobody on our panel is suggesting you get rid of your psychiatrist. I'm a psychiatrist. I prescribe meds all the time, but I really like the holistic slide that Denise showed. And meds are important, diet's important, exercise is important, sunlight's important, sleep is super important. There's so many things in the sort of the lifestyle, the life cycle of a human that need to be addressed to help these people heal that are afflicted. Here's one maybe for you. This is an area of research interest as well. Is a ketogenic diet bad for somebody who has a family history of high cholesterol or cardiovascular disease?
Ooh, Generally, probably not. If you're talking about familial hyperlipidemia and cholesterols of 400 and 500, that's a whole nother thing. If you're just saying, wow, you know, my dad's cholesterol was high and he had a bypass and my cholesterol is 240. No, we very frequently see cholesterol levels improve, HDLs go up. We do see LDLs go up sometimes. That's a really huge debate. And I will direct you to the Metabolic Mind website, and there are some really great videos on their YouTube channel. One with Dr. Brett Scher, who's a cardiologist, who is their main spokesperson and does the interviews, and he does some fabulous little talks on that. And then also Dave Feldman is a citizen scientist, and he is researching what's called lean mass hyperresponders with keto and people whose lipid profiles go up, but they are not laying down any plaque. And so that's a whole, well, research is beginning to show that. And it's like early research he's about to finish publishing. So yeah, generally I'll say, no, your cardiologist is going to flip. Okay. That's another day. That's another story. But if we can say, wow, you've lost 20 pounds, your blood sugar is good, you're no longer diabetic or pre-diabetic, your blood pressure is better, we're off 3 medications, maybe for blood sugar, blood pressure, you know, and maybe 2 blood pressure pills, which happens frequently, but your cholesterol is high. Yeah. And, oh, and you're not depressed anymore, you know. Yeah, I could go.
There's a debate. I don't know if it's debate. There's a sort of healthy discussion in the field right now with the sort of some of the cardiology factions being really worried about this diet having adverse effects in cardiovascular function. In my experience, what Denise has just said kind of wins the day. People who go through dietary modifications and get rid of all the free glucose and all the sugar water and all the stuff, whether it's a ketogenic diet or another dietary modification, look at some of the comments from Eric Adams, the mayor of New York City, who was type 2 diabetic, went into the doctor, modified his diet, and he's not on blood pressure pills anymore. He's completely changed his trajectory health-wise. So dietary modification is a big tool for that, irrespective of mental illness. We missed a question that was stuck in there. Can you do the ketogenic diet? I inserted that word if the person's refusing to take antipsychotic medications. So what I would say is if somebody's refusing to take antipsychotic medications, I would disambiguate that from whether or not you can do the ketogenic diet. I think if somebody is very ill psychiatrically, first of all, they need to be safe, whatever that means to that individual and their setting with their doctors and their family. And then it gets really complicated from there in terms of whether they have treatment orders or not. So compliance is a big deal with a diet like this. If somebody's willing to try a diet who's treatment resistant in terms of not wanting to take meds, I think I'd be all for that. But I wouldn't use it as an excuse to avoid the medication option. Denise, you want to editorialize on that?
No, I think that's great. I will say that sometimes what I see is when someone's refusing to take meds is sometimes they've been on many and they've had such adverse, you know, effects that sometimes they're saying, I won't take any more. You know, not that they have refused meds from day one. Sometimes it's like, I've tried 20 and I don't want any more, you know, so sometimes, but like,
Yeah.
I agree, they have to be
They get
safe.
fatigue. They really get medication fatigue sometimes.
Right. And we have to be wise. And if they're psychotic and, you know, and they may need to be hospitalized, you know, there's just so many factors in there and it's scary. And sometimes people they come to us and then they aren't in a good place. And then we get a call and they are in the hospital. Right. So, but we just say, we'll wait for you if the time becomes right for you, here we are. Because I've actually started people while they're inpatient from a Zoom call. If they're in a position to try to do it, you know, and that's not ideal by any means, but I'm just saying, if the willing person, you know, we can work with someone who's willing. We cannot work with people who are not willing. And that's hard because a lot of people are not. I talk to so many parents and I'm sure there may be some on this call, you know, so many parents that want us to work with usually their children, and the children aren't ready. And again, they, you know, that's the heartbreaking position of how do you get someone to the point of being willing to try this?
We have another question.
Dr.
I'm
Smith,
trying to
do you want to
go-
wrap up here, or would you like to take one more
we're
question?
gonna answer one last question. I think the chat, they covered a couple of the questions. Thank you for that, Amy Laughlin. Denise, how long do you need to stay on the diet?
How long? Oh, that's a great question.
I think we'll finish with that question.
You
Is that
tell
okay,
me.
Bethany?
We don't know. We don't know. And if you know something I don't, Rob, go ahead.
Oh,
Because,
I
okay,
know that in pediatric epilepsy cases, they'll be on the diet for a year or two, then sometimes stop it and the seizures stay away.
Mhm. Right.
But again, completely different situation. There's a lot of development
Right.
going on. The
And
brain is changing and growing, you know.
yeah, that is, the brain's changing and growing, and we don't know. And what happens is we'll say the gold standard of that is, say, do the diet for 2 years and then come off the diet and see. And 50% of them maintain the same seizure improvement, and 50%, that doesn't mean they were seizure free. They might have been 50% better. So they 50% maintain that, 50% go back to seizures at whatever level. So a lot of parents will say, I'm not taking my kid off the diet. This is the best they've ever been. You aren't taking that away from me. And then a lot of parents say, oh my gosh, I can't do this anymore. Okay. And that's maybe we loosen up and stop making it so strict. You know, I think we've come a long ways with loosening things up. So how long? I want them to try it for 4 months, easy. I mean, if I could say 6, but that's really pushing people, but 4 months, try it. That doesn't mean that's as good as you're going to get. Most people I've been working with, if they're getting better, they're continuing to get a little better, a little better, a little better. We don't know how long, but I would love to see people be hardcore for a year or two, and then can we pull back? And we're working on a consensus statement right now, amongst people that are using the diet, trying to kind of come to some agreements and say, what do people recommend? And that I'm sure it will be published within a year. I mean, I think they're shooting for 6 months, but a year is reality. So that's something to keep your eye out for. And that's going to be our first, attempt as a community saying what we think. And then, you know what, in a couple of years, we're going to come back and say, we know more. And now this is what we think. And it's not going to be exactly the same. And we're doing the best we can with what we have and just helping people as we go. I mean, to me, this is like a war, and like we're pulling casualties in from the from the front line, saving some lives. I really believe that we're saving some lives, and then we're going to go in and grab a few more, and then maybe one day the war will stop.
So I think we'll
Thank you
stop
so
there,
much.
Bethany.
Yeah, we can stop there. Thank you, Dr. Smith, Smita, and Denise. And thank you guys all for joining us. We really appreciate it. So have a wonderful evening. Goodbye.
Thank you. Thank you.